Today we're going to be, as I mentioned, talking about hospitalization information, and then we're going to have a chance to do an exercise where we see kind of how this looks in the data with a sample case and some, very limited data to try to look at some of the important variables. Then this afternoon, Beth will be talking about using the carrier and outpatient files, kind of what's the difference between the two files, what are some key variables, and then we'll have a chance to look at those in the exercise as well. So that's where we're headed. And just a review of yesterday to kind of orient you, we talked about how Medicare had a Part A and a Part B, and Part A is kind of their hospital benefit, and that some services that are Part A only will use the UB04 form. And that's where we're at with hospitalizations. There's really no reason for a hospital to use anything other than the UB04 form. They are institutions. There are other types of services that use the UB04 form, even though they are outpatient, like outpatient facilities, some home health. But for hospitalizations, it's kind of easy. We have one form to worry about. To get us started thinking about this, I have a polling question. If you've ever been responsible to pay for a hospitalization in the United States, for yourself or someone else, how many bills did you receive? Most people, a slight majority, got 3 or more bills. Some had 2. Some lucky few got 0. I want to know kind of how you've how you're covered. I know that when I had a baby, I was you kind of understood how this all works, and yet a little bit surprised because the bills just kind of kept rolling in slowly. You get the bill from the hospital. You also get a bill from the pediatrician and the family practice doctor and the neonatal nurse practitioner. They all come kind of separately. And what we're talking about in this segment is really just the hospital's portion of the bill. That's, paying for the rooms, paying for the nurses that care for you, any imaging, things like that that you get. That would be kind of under the hospital's purview, and they will bill on this UB04 form. Beth will be talking about kind of those physician bills that physicians saw me in the hospital, so they had a right to bill me, but they bill separately. It's not included in my hospital bill. So we have the hospital sending this UB04 form. And when we think about what we're going to see in the claims data, we have to think about what would be important for the hospital to communicate to CMS in order to get paid. So some of the information collected, patient and provider information. So who is the patient? That's important because Medicare needs to know, is this, someone that I need to cover or not? The provider information, that's important because Medicare needs to know, is this provider certified to provide Medicare services? Is it, what kind of provider is it? So that'll determine kind of the payment system that it gets paid under. And then, who am I going to pay? And then the dates of service. So again, this will be important for knowing, well, this is a Medicare enrollee, but are they covered under these dates maybe? So the claim date, the admission date, and the discharge date. The claim date and the admission date aren't always the same. There's a claim from and a claim through. We'll talk a little bit about that because of the way that hospitals are paid, and because it's possible to submit more than one claim for a single admission. Sometimes the dates aren't exactly the same, but you can figure out, when were they admitted, when were they discharged. And then there's a DRG code. And this is the basis of payment for most hospitals that are billing Medicare fee-for-service. And that is a diagnostic related group. And this is calculated based on the ICD-10 diagnosis and procedure codes that get placed onto the bill. Usually the hospital will also send along a DRG code, but CMS will recalculate it themselves, make sure that that's what they want to pay. And this is a way of paying. It's called prospective payment. Instead of paying on a fee for, even though this is Medicare fee-for-service data, they're not paying for every itemized little thing that happens to you in the hospital. They're saying, for someone with this condition that's maybe getting this procedure, this is about how much we think it should cost you to deliver the care. Now, hospital, you're in charge of making sure you come in under those costs. And then there's revenue center codes and charges, and that is the hospital communicating where things kind of happened in the hospital. They might communicate, well, there was an emergency room visit that led to this admission. Or they might say, this person used lab services, or radiology services. Those are all things that can be communicated in the revenue center codes. So now I'm going to talk about the inpatient files as opposed to the MedPAR. Inpatient files include all hospitalizations. So this is acute stays and inpatient rehabilitation stays. So they will both be found in this single file. They are calendar year files, and they're created based on the claim through date. So that determines which year that particular claim is going to go into. They're at the claim level. So as I mentioned, it's possible for a single hospital stay to be reported on more than one claim. This is really rare. So it's kind of weird that I keep saying it, but it is one of those things that you might, you go to look at the data and you're like, well, this is weird because it looks like these two stays for the same person happened at the same time. What is that all about? And just remember that this is a claim level file, not a stay level file. And so it's not two separate stays, but it could be two separate claims reporting a single stay. But it is pretty rare. And it's usually because the stay is crossing maybe the hospital's fiscal year. So it's important for their accounting to close one claim out and open a new claim. Something like that may happen. And it's usually, like I said, a longer stay. Claims, those claims, if they're the same, they usually have the same admission and discharge dates. So that's one way of determining that they're a single stay on two claims. So when we look at this, inpatient files, if you request them, when they come to you, you will actually receive a suite of files. The two most commonly used are the base claim file and the revenue center file. The base claim file has that, really important patient and provider information, the dates of service, what is the DRG code, what are the diagnosis and procedure codes that happened during the hospitalization. The diagnosis codes are actually discharge diagnosis codes. So at discharge, these are all the diagnoses that we've determined are accurate for this person. The revenue center file is separate. It has all of these different lines on it. So with the base claim, you get a single line per claim, but the revenue center file can have multiple lines for a single claim, one for each revenue center that's billed. And that will have dates and charges and lots of information on it. There are other files that you'll also get. There's a condition file, occurrence file, span file, value file, demonstration file. Personally, I've used mostly the base and the revenue center file, but if you're really interested in determining why is this hospitalization paid the way it is, you might need to look at the value file because there might be special circumstances. Or if you're interested in demonstrations, you can get demonstration project information in that file. The occurrence code file might give you information like this was a car accident, and so there's a reason that maybe Medicare isn't the primary payer. So I would encourage you to look at these files and kind of pay attention to them. They can be really useful. I know we've had students that have used them, but oftentimes if you're looking at clinical information, which has been kind of where I've been, the base and the revenue center file are kind of the ones that are used the most often. As I mentioned, revenue centers are reported on the claim. They are provider assigned a revenue code for each cost center for which a separate charge is billed. So again, this is the hospital's kind of doing an accounting of, where in the hospital did services take place. There are, is it a private room or a semi-private room? Is it a med-surg room or an ICU room? Did they use the pharmacy? Did they use the laboratory? And most of the time you will see multiple revenue centers billed during a hospitalization, of course. And then there is a revenue center code 001. It actually shows up on every claim. So every claim has at least one line with 0001, and that's a total of all the revenue centers included on the claim. It's important to just kind of note that. So if you're like adding charges, you won't count the same charge twice. For each revenue center and the associated procedure with that revenue center, you get information on that file about, how many units. So if it's a day of stay, the service units might represent days. They might represent something else. If it's an observation stay, maybe they're representing hours. And then you'll get a charge for each revenue center. That's again calculated by the hospital. Payments are not made at the revenue center level. They're made based on the DRG that's assigned from the ICD diagnosis and procedure codes. So just remember that it's really hard to say, this is how much, Medicare paid for this emergency department visit that happened, in the context of this hospitalization because Medicare doesn't break it down that way. They pay the one DRG. But you can see what the hospital is assigning as charges for each of these. This will allow for detailed analysis at the revenue center level. But just note that revenue centers aren't required to be the same across hospitals. Medicare has some expectations. They say we expect, emergency departments visits to use these, and revenue centers are defined. But if facility one only has a general ICU in which everyone comes, if it's a surgical patient or a neurological patient or a trauma patient, they all go to that single ICU. They may just use a general ICU code, whereas facility two may have multiple different ICUs and they all have different revenue center codes. So just note, you may have to look generally if you're like, oh, this is great, I can identify cardiac ICU. You will be able maybe to identify if a hospital is listing that as a revenue center, but you may need to look more general and use diagnosis and procedure codes to get more information. This is what it would look like when you have a base claim and a revenue center file. Obviously, this isn't all the variables, but you can see we have a single beneficiary and a single claim ID, and the base claim is just one line. The revenue center file, in contrast, will have multiple lines for this one claim, and they have a line number, so you can see that. Here we have the revenue centers that are being billed. We can see from the DRG this is a fracture and their principal diagnosis tells us it's a lower right leg fracture. And then when we look at the revenue centers, we can see, well, there was ER use and diagnostic radiology use and pharmacy use, and they had a med-surg room, semi-private. And then we have this summary. So that's just the summary line is important to know about. Again, if you're planning on summing revenue lines, just note that this revenue charge is the sum of all of these. So you don't want to count them twice. And yeah, so that's the summary line. So now we'll talk about the MedPAR file, and this is a stay level file that was designed for policymaking to try to make it, a little bit easier. You don't have to worry about 2 claims per stay. It is created from the same information, and I think I said this yesterday too. It's the same information, the same bill, all of this that the claims file is created from. I said that it was created from the claims files, which isn't exactly true. They're kind of both created from single source though. So the same information underlies both the MedPAR and the inpatient files. And the MedPAR includes both hospital and skilled nursing facility stays. This is part of that rulemaking process. I think, they wanted to track people from hospital. In this, you will have hospitals, possibly rehab, plus skilled nursing facilities. You have a lot of information on this one file then. For hospitals, it has both short stay and long stay hospitals, mostly short stay, and then it also has skilled nursing facility stays. So about 14% of the stays are skilled nursing. It is a calendar year file again, but it's based on the year of discharge for hospitalization and the year of admission for skilled nursing facility stays. I kind of remember this, it's a rulemaking file, so it makes sense. You want to, as much as possible within the same year, try to track someone, from hospitalization to skilled nursing facility stay. And then each MedPAR record is one stay, as I've said before. And inpatient files do not include skilled nursing facility records, just as a note, but there is a separate skilled nursing facility file that you can request. So MedPAR is a bit of a shortcut if you want both, and it does have a lot of the information you probably need. So you might be thinking to yourself now, okay, if it's just one line, but the inpatient file had all of those different files, plus lots of lines per file or per claim, how does that work? What they do is they make the MedPAR really wide. It has lots of variables, and there may be a switch that says, yes, the CT scan revenue centers were billed. So it's like a yes, no, or it's yes if it's billed, but blank if it's not. Or there might be a charge amount. So there's an ER charge amount variable that will say how much, what are the charges that are assigned to any emergency room revenue center. And you can say, well, if it's less or if it's greater than 0, I will assume that the emergency room was used during this hospitalization. Sometimes it has intensive care unit day count variables or ward day day count variables. You can see how wide this is getting, right? And sometimes it also has indicator codes with more detail. So it's blank if the revenue center was not used. Otherwise, it might group the services and indicate the type of use. So one example, I guess I don't have it on here. The intensive care unit indicator will say, whether it's a general or a neurological. It's just a way of trying to get you more information in a single variable. This is an example of what the MedPAR file would look like, but now I have 2 lines here, but just note that you should imagine this as one long line. And this is, for a single beneficiary. We have the principal diagnosis. We have all of this on a single line, the Medicare payment. We have that a pharmacy charge was used. We have that diagnostic radiology was used. We have an ER charge amount. So we have, and that an SMI private room charge amount. So it's got all the same information that previous example had. It's just on one line. And you can see that ICU indicator code here is blank because they didn't use any intensive care unit. So that just means it's not used. So research file differences from claims forms. We talked a little bit yesterday about how the claim form is submitted, but then once we get the research files, we have some variables that on the form which are not in the research files. So we have things. That aren't on the form, like payment. The hospital is submitting the bill for payment, but the final decision on what the payment should be and what the payment actually is gets added after the form had been submitted. So we have things like reimbursement, primary payer amount. If there's a payer other than Medicare that pays first, we have that information. We unfortunately don't have information on who that payer is. There's information on copayment and deductibles. We have days from admission to death are added to the MedPAR. That's a calculated claim. And anything that's been done to the claim as it's moved through the process will kind of show up on the claims form or on the research files, but they weren't on the original claim form. There are things that are reported on the claims that aren't retained. So we don't get patient name and address. We don't need that. We have Benny ID, which is great. We don't have the non-Medicare insurance information, as I mentioned. And physician identifiers are reported on the claim form. So this will be like the admitting physician, perhaps, sometimes operating physician. It's removed from the MedPAR. I will say that if I really want to know about the physicians that treated a patient, I will probably defer to using the carrier and try to match up the dates, because sometimes, if the attending physician, it could be a very general thing. The physician isn't getting paid on the basis of being named on this claim form. It's just, an assurance that a physician was in charge of the care. So I would probably defer to using a bill, which is important for payment. We also have patient demographic information that is reported on the research files. So we have age. It's reported in the MedPAR in years with no cap, so it can be 3 digits. But the MedPAR itself doesn't have date of birth. On the other hand, inpatient file gives you date of birth, but not age. So you can calculate it using date of birth and the admission date. But MedPAR, that work has just kind of been sort of done for you. We also have the state, zip code, and county of the patient. That's based on information from CMS sources at the time the bill is processed. So we sometimes say, well, you have all of that information on the MBSF, so you can just use the MBSF. Sometimes you'll see a difference between the MBSF and the claims file, and that is usually where we would attribute that to the person probably changed residence between when that bill was processed and March, which is at the point in time in which the MBSF record is created and finalized. But it's actually much less than you would think. I think that was sort of surprising when we first looked at it, because it seems like it should be, you'd have people moving around a little bit more, but it's reasonably steady. We also have diagnosis procedure codes and DRGs, as I mentioned. So there can be up to 25 discharge diagnoses reported for each claim. Before 2010, it was only ICD-10 diagnoses, but you can see that there can be a lot of information that's reported on the claims. It was ICD-9 September 30th, 2015 and prior, and then starting October 1st, 2015, it's ICD-10. So it's a kind of a strict cutoff. For procedures, same deal, up to 25 since 2010, ICD-9 and ICD-10, same dates, but that got changed. And then the MSDRGs are what we see here. There are other systems, other insurance companies that you might be looking at their data, and they may use a different kind of DRG. There's APR DRGs as well, but Medicare is using the MSDRGs, one per stay, assigned based on what is reported on the diagnosis and procedure codes. There's also an admission diagnosis code, and that's separate from those 25 discharge diagnosis codes. It's oftentimes, it looks more like a symptom. It might be like nausea. And then the discharge diagnosis codes are going to explain, what was discovered during the hospitalization to explain that admission diagnosis code. It is there, but it shouldn't be seen as a primary diagnosis. So just a little bit about ICD-9 and 10. As I mentioned, we have the date cutoff. That's when it changed over in the claims. And you might be like, well, October 1st is weird. Why didn't they just wait for that calendar year file? October 1st is actually the start of the federal fiscal year. And that's, I think Beth mentioned, sometimes when you're looking at your data and you're trying to figure out things, it's really good to plot it by month. It's not unusual to see things change October 1st, or sometimes, June 1st, because sometimes there's a quarterly change. So just note that October 1st is, federal fiscal year. Going from ICD-9 to ICD-10, just the sheer number of the codes. For diagnosis codes, we went from 13,000 to 68,000. For procedure codes, it's huge. It's from 3,000 procedure codes under ICD-9 to 87,000 procedure codes under ICD-10. Back when I was working with ICD-9 data, you could get a procedure code from the hospital information. It would tell you, oh, they had a radical prostatectomy. But it wouldn't tell you anything, any details about, was it minimally invasive? Was it, what kind of procedure was it? Now with ICD-10, you get a lot more information about that. You can still use the CPT codes on the physician file to get more information about the procedures, but you do have a lot more. We're going to be talking about E codes and V codes a little bit further on in the presentation. Just note that they mean different things under ICD-9 and ICD-10. So E and V are the first letter of the diagnosis code. And it's usually a number under ICD-9, but if it did have a letter, that would tell you something about the code. It would tell you if it's an E code, it's an injury code. If it's a V code, it's a other factor that affects their care. But when we go to ICD-10, completely different meaning. E means metabolic conditions. V is external causes of health problems. So just things to note. As I mentioned, you can have up to 25 codes. And actually, there is, a mode at 25 because hospitals do have an incentive to list all of the possible things that are going on with this patient. When the DRG is calculated, the more complicated their care is. You can say, well, this was not a simple hospitalization because we were also trying to help manage their diabetes, and they have a pre-existing, atrial fibrillation, and they're on blood thinners. So like you're trying to say, these are all the things that are influencing how much it cost us and, what the level of care that was required, even though it looks like the same hospitalization as this other person that was very healthy. So the diagnosis codes give the hospital a chance to communicate that. You can see that there are lots of hospitalizations that don't have a procedure code. And that is because ICD-10 and ICD-9 procedure codes are really, they're major procedures. They're, usually a surgery or something like that. Sometimes you'll see, well, there's a ICD-9 code for something relatively minor. Those don't tend to get reported because they're not going to influence the payment. So it's important to note that, just because there's a code there doesn't necessarily mean it's going to get billed. As Beth had mentioned yesterday, we're looking for things that influence payment. So it's important for us to understand how the payments are calculated to know whether we can expect to see it on the claim. You can use the diagnosis and procedure codes in combination to help you define clinically different groups. So we can have, if we were looking at a procedure of total hip replacements, it probably makes a big difference to us whether that hip replacement was happening as an elective procedure because of osteoarthritis, or whether it's happening, relatively emergently after a fracture. So, and you can see if we do this, separating out the two groups, we can find that there are differences. We have, much younger median age for the elective procedures, shorter length of stay, more are discharged home. They were able to set up, care for themselves at home versus someone who's getting this done emergently. They didn't have a chance to do that. We have higher mortality after fractures, more likely to be discharged to skilled nursing. So you can use this information to help you refine, what you're looking for in the bills. I mentioned before we were going to talk about V codes under ICD-9. These that used to be V codes are now found under ICD-10, beginning with the letter Z. These are supplementary classification of factors influencing health status and contact with health services. It seems like they should be relatively rare, but in fact, over 80% of hospitalizations have some V code, and some of them have them within the first 10 codes. So, and there's even some that have it as a primary reason. It can be a little bit funny because if you look up what the code means, sometimes it says history of breast cancer, but you see that they're having a mastectomy. So you just will have to, it's important. The reason that we bring this up is because you may think, oh, I've got all the breast cancer codes. I don't, history of breast cancer is not something I'm interested in. But you may want to include it. As Beth had mentioned, sampling wide and analyzing narrow, you can decide after the fact to say, well, actually, it looks like that's not telling me what I need, but maybe you do want it. It may get you some information that you wouldn't have had before. The other weird thing about this is that it can sometimes be denoting prophylactic organ removal. So maybe this is a contralateral mastectomy, so they're removing the breast that's not affected. But it's in the diagnosis code field. So it seems, a little counterintuitive, but it's a way of looking for more information. And then maybe it's aftercare involving the use of plastic surgery. So it's telling you something that's actually happening during the hospitalization as a procedure, but it's in the diagnosis code field. And sometimes they do describe receipt of treatment. So you may see a V code or a Z code that tell you that there's chemotherapy being delivered, or a general psych examination. So just be aware that those are there. There's also something that are called present on admission flags. This is an indicator for hospital-acquired conditions, and it became a requirement after 2007. There are some hospitals that are exempt from reporting, and like the non-PPS hospitals, and some codes that are exempt from reporting this. And you'll see that influences kind of how it appears. The hospitals are paid less for conditions that are not present on admission, right? So the DRG is described as, discharge diagnoses and procedures. But the CMS says, well, but if it's something that maybe was caused during the hospitalization, we don't necessarily want to pay for that. So this is a way of communicating that. It's required for every diagnosis field on the claim. So you have 25 fields describing diagnoses, and then you have one flag for each one of those fields describing whether or not it's whether or not it was present on admission. So this is kind of what it looks like. Yes, it was present at the time they were admitted. We can't really tell. We think that probably was. No, it was not. We think it was, but we don't have enough documentation to support that, or maybe it's unreported or not used. So it's either the hospital or the code is exempt. For this one, it's starred because it's not, CMS isn't paying a DRG. So the code isn't, it's a little bit unusual. It's different in how CMS is using the code to calculate their payment. But so you can see that CMS will pay for it if it's yes, if it's, we can't really communicate, or we can't really determine, but we have some evidence, and then no, they will not pay for it if it looks like something that maybe has happened as a result of treatment. When we looked at, We looked at acute myocardial infarction claims and saw how often was diabetes reported as a pre-existing condition. 98% of the time, but sometimes they couldn't say for sure. They were treating the patient for it during the hospitalization, but they didn't have evidence that it happened or that it was there before. I also mentioned that there are E-codes. This is important because you'll actually see variables on the file that are labeled E-code. So these are mechanism of injury codes. They communicate that this traumatic injury is as a result of something, it's a car accident or a fall. It's separated out from the diagnosis fields in 2011. So prior to that, you could find them intermixed with those 25, or actually at that time, 10 diagnosis codes. But now they pull it out. It's not required for payment. So you can get, injury researchers can get, pretty excited about E-codes. They're just, sometimes they are there and sometimes they aren't. Some intermediaries really strongly encourage them, and some states really strongly encourage them, but you don't always see them, even if it looks, this is obviously an injury to a person, but for some reason we don't have an E-code. There are multiple fields that are allowed on the claim form, but there's only data in the first code field in the claims, just so you know. We have a student that was really interested in injuries, so they put together this for us, just looking at, like how often are E-codes reported? If it's something like a drug adverse event or a pathologic fracture, oftentimes you don't find an E-code. If it's a burn or a complication of trauma, you start seeing more E-codes. And then for injuries like, head and wrist injuries, you see many more E-codes that are populated. And it does differ by setting as well. In the inpatient files, we do see a pretty good reporting rate of external causes on the claim. Outpatient is slightly less and carrier is even less, but then if you say, well, I'm going to limit it to the emergency room, then we get more. So just be aware of that. And unfortunately, as Beth had mentioned yesterday, if just because an E-code is present doesn't necessarily mean it's super informative for you. About 30% of hip fractures that we found had no E-code. If they did have it, sometimes it's unspecified. It doesn't really tell you where it happened. So just hopefully, they'll evolve as they go, but sometimes you just don't get a lot of information from them. The limitations of diagnosis codes. There is a chance that there's uneven coding. So larger hospitals may have better systems for their coders. They're able to invest in a really helpful EHR or, code mapping system, or they might have better quality control. They have more resources to put into making sure the codes are correct. So you can see this. There was, an idea that rural hospitals, it looked like they had much healthier patients, but they had worse outcomes. What was that all about? It could just be that they're just putting less resources into documenting every possible comorbidity that someone might have in the hospital. For non-hospitalization bills, I say this because this is where diagnosis codes are introduced. Hospitalization bills, we get a discharge diagnosis, so it's usually relatively firm if it appears on the claims. But on a carrier claim where it's just reporting one day, one quick visit, you may see something like a rule-out diagnosis. So you may see a diagnosis of prostate cancer and a PSA screening being billed. If you never see another diagnosis of prostate cancer, you might just say, well, I'm thinking that they probably didn't have it. That was just being billed to, say they're looking for it. So you might find that. This is the basis. Nate will talk about algorithms for flagging conditions, but it's the basis for saying we only require one hospitalization to feel confident that someone has a condition, but we require more than one carrier bill on a different day. So going back to the MSDRGs, this is part of the inpatient prospective payment system, and it was first instituted in 1983. So it's been around for quite a long time. It sets a single payment rate per discharge that represents the average cost of treating patients with similar conditions and needs. So, this patient came in with, atrial fibrillation, and we did a cardioversion that should cost about the same. And when I say it's a single payment rate, it's a single base payment rate, depending on where the hospital is in the country, there might be a different wage index that's adjusted, but pretty much it's just to say this is a grouping. They look for similar conditions with the diagnosis codes and the procedure codes. There is a small number of DRGs that also take into account age or sex or discharge status. If someone is discharged deceased, they may have a different DRG code assigned to them. Using DRGs to try to find care can be tricky. So, if we said we want to identify all the hospitalizations where there were fractures of the hip and pelvis. So if we search the DRG manual for that, we get these 2 DRGs. Great, that's what we need to look for, right? If we use diagnosis codes instead, we find that only about 5% of hip fractures are using these 2 DRGs. And that's because we find that, many people that have a hip fracture end up having surgery. And there is a separate DRG for surgery that doesn't say fracture of the hip. It is called hip and femur procedures. Now, I wanted to list these 3 out because it kind of explains why you might see more diagnosis codes billed and why we see up to 25, and oftentimes people bill all 25. The average total payment for one that can document major complication or comorbidity is $26,000. The average total payment for someone who can say, well, they've got a complication or a comorbidity, $17,000. And then if they can't really say, based on the diagnosis codes, that they have, any complicating conditions, then the payment is less still. So that's kind of how the DRGs are calculated. It could be, same service, but if you can say, there was a lot of other stuff we were managing during this hospitalization, then the payment increases. So we have another polling question here, and it would be, if you were told, you need to identify a breast cancer surgery hospitalization for me, how would you do that? Would you use DRG codes, diagnosis codes, procedure codes, combination? Most people said diagnosis or combination of diagnosis and procedure codes, and that is what I would use. You can use ICD diagnosis codes. You can say, well, they're in the hospital for breast cancer. Chances are good they're getting surgery, or maybe I want to know what else they could be in the hospital for breast cancer for. If the diagnosis codes for the procedure codes for breast surgery you feel like are specific enough, you could say that. Either way, if I was choosing based on that, I would probably want to use look at both of them in combination to make sure that I was measuring what I thought I was measuring. And some of you did say DRG codes. And I would say that if you have a really specific reason you're looking at DRG codes, you want to look at, how different hospitals are billing the DRG code, or how they're, what their cost to charge ratios are under that code. You could do that. You could try to find them based on that code. I would probably use diagnosis and procedure codes to do my initial identification and make sure I have what I think I have, and then you could use the other ones alone. Hospitalization information. I guess were there any other questions that okay. Oops, excuse me. So information about the hospitalization in general. As I said, you may want to know what is the length of stay when someone has this procedure. We do have admission and discharge dates. They're present on both the inpatient file and the MedPAR. The MedPAR also has a calculated length of stay variable. The important thing to know about this is that it's never 0. So even if someone were for some reason admitted and discharged on the same day, it just becomes 1. So if you needed to know how often that happens, you would want to use the dates. I'm sure it's rare, but maybe you need to know, you want to see how often someone does that. They maybe leave early for some reason. And then just to note on the MedPAR, the length of stay for skilled nursing facility stays is different. It's paid as a post-acute care benefit. There's a limit in covered days of stay, but sometimes people they're not discharged to home after their covered days are done. They stay on as a private pay patient. And so the discharge date doesn't look exactly the same. About 20% of SNF stays have no discharge date at all. And that's one of the reasons. So looking at the admission type, there is a variable that says, was this an emergent admission, urgent, elective, newborn? This is reported by the hospital, not related to reimbursement. So remember what we said yesterday. We usually put more faith in things that are related to their payment. It's usually scrutinized more, making sure that it gets reported correctly. It does usually make sense. We can see that if we looked at hip replacements that were related to fracture, oftentimes it's reported as an emergent or urgent. There may be reasons why it might be an elective procedure. I don't know, so you might say, well, do I say that 2% of the time there's some urgent need for a hip replacement for an osteoarthritis patient? It's possible. It's also possible that it was just coded that way. As one of our TAs likes to say, everywhere there's a coder that's on their first day of work or their first week of work. So sometimes you might see a mistake that never got caught because it didn't matter for the payment. There's also a discharge destination that's provided by the hospital. So they might say discharged to home or self-care. They might say transferred to another short-term general hospital. There is a field that says whether or not they died. This is usually consistent with the information found in the MBSF. Medicare uses this information as a report of death. It's not the final say. They will verify that with the Social Security Administration, but it is one source of information that they use to pull in to say, we have reason to believe this person has died. When we look, and that actually can influence payment status, discharge of death on very few DRGs, but it's important to know how things are paid. When we look at our hip fracture or our hip replacement cohort, it does, seem to make sense. We have more skilled nursing and inpatient rehab and mortality after a fracture versus an elective procedure. But because it doesn't necessarily influence payment, I would also like to know, if I can get claims evidence that I can find a claim confirming that they were indeed discharged to home health or to hospice. Because, it may be that at the time of their discharge, they had every intention of setting up home health, but for whatever reason, it didn't work out. Maybe a family member said, I'm a nurse, I can do that. So anyway, having claims evidence can just be helpful to know whether or not it happened. And this is how often when the discharge status says home health within 30 days, how often do we find a home health claim? So home health is kind of the least. Hospice is a little bit better. Skilled nursing facility is, even better. And you can imagine that that's one where they probably know as soon as they're discharged whether or not they're going to go to a skilled nursing facility or not. They usually go straight there. We do sometimes see hospital outpatient care. So as I mentioned, an emergency department is really an outpatient portion of a hospital. A lot of people come and they never are admitted to the hospital. They leave. It's an outpatient department. Observation stays are also considered outpatient. So someone maybe just needs to be observed for 16 hours just to make sure that, whatever treatment they've received or, that their injury isn't getting worse. So those are both outpatient, but if someone comes into the emergency room and is admitted, maybe they're being observed and it's decided that they need to be admitted, then their care might be reported on the inpatient claim. And that's because of that prospective payment. Usually if they use an outpatient department and are admitted to the same hospital for the same reason or, for the same diagnosis within 3 days, it's almost always grouped within. If it's a non-PPS hospital, maybe it's a critical access hospital, that wouldn't necessarily be the case. So you would definitely want to be making sure you're looking in the outpatient file. Or if it's, they went to the critical access hospital for their emergency room use, and then they went to a different hospital for if they went to 2 PPS hospitals, but they're different, then you wouldn't expect it. So I would say always use outpatient and inpatient files in combination if you're looking for emergency department visits. But also note that you will see this outpatient care, and that's the reason that it's appearing. For provider information, We have a CMS certification number on the inpatient claims. It used to be like, yes, there's always a CMS certification number, but now with a rise of encounter data and the TAF data that we're using more and more, it's like we don't actually get this number. But this is a number that's assigned by CMS when the hospital applies to be certified to provide services. It's a 6-digit number. Usually that's what we get. And the first 2 digits are always the provider state code. And the final 4 digits tell us about the type of provider. Usually really the middle 2 kind of can help you identify what type of provider it is. 00 to 08 in the middle 2 digits will be acute inpatient, short-term acute care hospitals. If it's, starts with 40 to 44, it's a psychiatric hospital. We also have, so this is, it's not called CCN on the claims files or the MedPAR. It's called provider number. They have slightly different meanings up until 2021. So we'll talk about that. The third digit of the third character of the CMS certification number is sometimes a letter. So if it is a letter, that usually means that they are there's a special unit that's operating within a short-term acute care hospital. So if there's an inpatient rehab unit that's actually just part of the hospital, it's just a different floor of the hospital, then it might have an R or a T in this third position. Or if it's a psychiatric unit within a hospital. This would be distinct from a rehabilitation hospital that someone, moves to after their stay. That would have its own CMS certification number with, I guess for a psychiatric hospital, if it's a psychiatric hospital, it would be 40 to 44, or it would be an M or an S here. And that just tells you, is it a separate hospital or is it a unit within the same hospital? The reason this is being communicated to CMS is because rehabilitation and psychiatric stays, they have their own separate PPS payment system. So, that's one way to tell CMS, pay us under this payment system. And the reason that the encounter data don't have that is because they're not asking CMS for payment. They're just asking the managed care provider for the payment. There is the MedPAR provider number prior to 2021. It never has a letter here. What they would do is they would actually remove that letter and create a separate special unit code variable. And then they had some rules for replacing it with a 1 or a 0. That's in the data documentation. You can see that. Starting in 2021, it's kind of more matches the inpatient provider number, but they do have a separate provider base CCN number that will look more like the previous MedPAR provider number. Critical access hospitals, I've mentioned them before as an example of a non-PPS hospital. They were created in the 1997 Balanced Budget Act. There were rules to say, well, this hospital is critical, it's so far away from other hospitals, it's serving this population, and as a way of making sure that they received a payment that would help them to stay open, right? It was implemented over a period of years extending into the 2000s, and the rules kind of changed over time, so different hospitals became more eligible over time. When a hospital goes from being a short-term acute care hospital to a critical access hospital, they get a new CCN. So that's the reason we're telling you about it. If you're trying to track a hospital over time, you might need to know that this happened. There is a provider of services public use file that has a field called cross-reference provider number, so you can use to track the same hospital over time. The other thing to note is that in the MedPAR, there is a short stay, long stay, skilled nursing facility indicator. Just by virtue of their numbering system, critical access hospitals are categorized as long stay. It doesn't mean that all of a sudden the patients stay longer than they do for a normal short-term acute care hospital. It's just the way that they are designated. So just be aware of that. I would say if I'm looking for general hospitalizations, I would always include both short stay and long stay, and not include the SNF if I'm looking in the MedPAR. There's also another provider number called the organizational NPI. If you've worked with other payer data, you're probably familiar with this. This was an intelligence-free identifier, meaning that none of the digits have any specific meaning to, what kind of provider it is. It's the HIPAA standard since 2008, I believe. So it's assigned to organizations. Now, they're not one-to-one if you're looking at CCN versus MPI. There are some MPIs that are associated with more than one CCN. There are some CCNs associated with more than one MPI. So there's not a lot of people are looking for a crosswalk, especially people that have been using fee-for-service data and want to start using encounter data and thought, the CCN is really helpful for saying, this is a rehab stay. But unfortunately, you don't get that with the NPI, and you can't really, there's not a crosswalk that someone can give you that will tell you, for sure, this is the CCN that's associated with that NPI. Unfortunately, they just arise from different sources, really. The facility applies for them separately. So whether you're using CCN or MPI, there are some external files that you can use to pull in for more information. There's a provider of services file that is created from the CMS surveys of the facilities. So they're, saying like, how many beds do you have? Are you a teaching hospital? So you can get that information and merge it in if you need some of that. There's also the healthcare cost reporting information system, sometimes just called the cost reports. That has information that the hospital is reporting out about their financials, but it also includes, are we a teaching hospital? How many beds do we have? How many bed days are we billing? So it can be really helpful information to link to, and those would both be CCN level. They're both CMS files. The MPI links to the National Plan and Provider Enumeration System, which does give you a taxonomy of the type of organization. So you can use that as well to link to, to get more information. And if you want to see more about those, we have a link there for you. And then I know I've talked about the prospective payment system a lot, but just to note that there are providers that aren't paid under PPS. Almost all are, but Maryland has its own system. So there are no PPS hospitals in Maryland. There are 10 cancer hospitals that are PPS exempt. And then any critical access hospital is not paid under prospective payment. So there's an indicator that can tell you, was this stay claim prospectively paid or not? Overall, about 8% of stays are non-PPS. But if you are looking, the DRG is still going to be populated, even though that's not the basis of payment. The information that's presented on the claim might look the same. They may not have the same incentive for, billing diagnosis codes. So it's important to know if you're looking at cancer hospitals, how are they paid? What might I expect to see based on how they are paid? And then inpatient rehabilitation. I mentioned that there are inpatient rehab stays in the file. The provider numbers range in the 30s, the 30 in the third and fourth digit. If you're looking for transfers, just note that you might need to remove rehabilitation stays, right? Because they're not actually going from a general stay to another general stay, they're going from general stay to rehab. So you can also find them, you can find them with the provider numbers, you can find them with the special unit code of a T. So just note that if there's rehabilitation that's being provided by the skilled nursing facility, that's actually going to be part of the SNF file, SNF claims file, or SNF MedPAR. So you're going to want to try to, if you're calculating readmission rates, also you want to differentiate between readmissions and transfers. And you can do that by saying, well, is it the same provider number? Would be one way. You're going to have to make some decisions about what you're going to count and what you aren't. This is one of those cases where we don't get, yes, no, this is a readmission. You're going to have to use the information that you have. And you're probably going to want to make sure to remove rehabilitation stays again. So yeah, comparing admission and discharge dates can say, well, this is, not likely to be a transfer because discharge and the discharge date of the first hospitalization doesn't match the discharge date of the second hospitalization. You can look at the provider number. Lots of pieces of information to help you. Now, physicians, as I mentioned, they do show up on the claims form, and they do show up in the inpatient file as an NPI since 2007. They also have UPIN, before that. And you can link this information out to other sources like the NPPES or the AMA master file. There is, things like the attending physician NPI, the operating physician NPI, other physician NPI. Unfortunately, there's not enough that probably every physician that's billing during that hospitalization can show up on that claim form. And it's only found in the inpatient file. And I would say I would probably just defer to the carrier to try to figure out, all of the different physicians that are billing during that stay, because it's not important for payment. There are things in the MedPAR called information-only claims. So I've said this is our fee-for-service class, and inpatient claims are only fee-for-service. The MedPAR actually considers or includes some stays that are coming from hospitals. They just need to report to the Medicare program that they're seeing Medicare patients because they're getting a payment from Medicare that is contingent on the number of Medicare days that they have. So they send this claim to CMS not to get paid, but to report that there was a stay and that they need to be counted as these patient days. You can't really rely on them having zero payment amounts in the DISH or IME or greater than zero in order to identify them, identify hospitals that are reporting for this reason. When we've looked at, now that we have the encounter data, we said, oh, this is great. We've always wondered how complete this data is. It's not super simple because when we look at the encounter data and the MedPAR, there are some stays that are reported as Medicare Advantage that only show up in the MedPAR. There are some stays that are reported as Medicare Advantage that only show up in the encounter data, not in the MedPAR. And then there's a bunch that there's about 90% show up in both. So, and it's, kind of improving over time, the MedPAR match rate. It's more common for larger urban hospitals to have Medicare Advantage paid MedPAR stays. Maybe it's a resources thing where they're able to send that information to CMS. Sorry, I know I'm running short on time here. Some of the weaknesses of inpatient hospital claims, medications, likely are being provided during an inpatient stay. We don't see them. We might see a pharmacy revenue center, but we don't have an itemized list of medications. We don't have timing of events. We don't know, how long it took them to get from the emergency room to the cardiac cath lab. We just know that cardiac catheterization was performed. And again, different hospitals may have different recording of those extra diagnosis codes. But, we have really good information on who this person is, when are they seen, because that's important for payment. We have diagnosis codes and procedure codes that can help us know what's going on during that hospitalization. And really importantly, these have the beneficiary ID that Beth had mentioned exists on the MBSF and all of these. So we can follow someone from hospitalization to outpatient. We can see, rehabilitation or transfer. We can see all of these things because we have a unique identifier that can merge everything together. So MedPAR is a little bit easier to use than the inpatient file. You get slightly more detail with the inpatient. You have to decide kind of if you need that. And then from either, you get all of this great information about the stay. This is, I'll just let you guys have this in your slides. It's just kind of a quick, what do I have in the inpatient? What do I have in the MedPAR? And then I just wanted to note that there's a lot I didn't talk about in terms of, questions that you might have about this. Please feel free to, when the special unit code was removed, how does that change the provider number? What does that mean? More information about those information-only claims and how do you identify them. That is all stuff that you can contact ResDAC about.